So today we'll discuss this mechanical complications of acute myocardial infarction. Today, the first we'll have an overview of all the mechanical complications, which is interventricular septum rupture, then is the rupture of the free wall of the ventricle, and third one is the papillary muscle rupture or necrosis. And we'll give an overall what is the current status of this, what is the incidence and what is the outcome. Then we'll basically focus on the most common complication, which is rupture of the interventricular septum. If you can't hear me, just let me know if there is any issue, okay?
Okay.
Yeah. So these three complications, although they are the rare, but in you will see in your career, you will see some cases like this, and presenting with acute cardiogenic shock, then followed by the morbidity and mortality very high among the all cardiac surgical procedures. So what is the overall incidence and prognosis of these complications in the current era? This is one of the important papers which I found out. I recommend everyone should go through this paper and read it out. I will summarize this paper first before we go to the VSR focus. In this paper, if you can see, there is it's a big series of patient admissions which has around 9 million cases. Around STEMI were around 4 million and non-STEMI more than 5 million cases. And then what was the mechanical complication rate? It was 0.27%, which is pretty low. Then in the non-STEMI, it was around 0.06. So you will see mechanical complications both in STEMI and non-STEMI. When you see the mechanical complications STEMI, it is again, we divide into three parts, like papillary muscle rupture, which is 0.05, which is the second common, and the VSD, or you call it sometimes VSR, which is a commonest 1.21%, and free wall rupture, which is 0.01. Similarly, in the non-STEMI, you will see the free wall rupture 0.01, then 0.04, and 0.01. So we see the non-STEMI as well, but the incidence is pretty low compared to the STEMI. In this slide, you can see what is the temporal changes in the hospital mortality and the overall incidence. So if you see the mechanical complication is overall, which is the top one, is the blue line, which shows like, in over a period of more than a decade, and this is around 12 years data. In 2003, the incidence of the mechanical complication STEMI was 0.25%. Now it is actually the graph is going up. So we do not see any decrease in the incidence of mechanical complications in the present era. Even we have advanced in our management of the MI patients. Similarly, if you see that the commonest one is the VSR, then we have the papillary muscle rupture and AV rupture, all have stayed the same from over 12 years. Did we progress anything in the mortality? No. In the 2003, our mortality in the patients was above 40%, like say 40, 42, 43%. If you compare to 2015, there is bumps up and down, but mostly it stayed static, like it is around 40%, which is the highest mortality rate in the cardiac surgical procedures. In the non-STEMI, although the overall incidence is very low, like 0.06, but the trend has not changed at all. And similarly, the mortality and outcome of these mechanical complications in case of the non-STEMI patients also is same. It was around 18 or 20%. And though the graph came down at some stage, but it is back to the square one, so same. So we didn't improve in the incidence, and neither the incidence has come down over this mechanical complication over the last decade, and neither has the mortality come down. When we subgroup analysis, when we see what were the factors which were affecting the mortality outcome, the most important, if you see the STEMI group, the age, elderly people, they do the worst. Or the younger, they do better. Similarly, when we do the gender, The females in this case have, particularly in the STEMI, they did the worst. But in the male group, they were the better outcome was better compared to the female gender. In the non-STEMI group, again, if you'll see the elderly people, elderly female, they were the worst, and the younger were the better. But if you see here, the graph is different. The females did not show, they were better, outcome was better compared to males. I went through the paper, I did not see any reason why the males did in non-STEMI better than the male. But this is a general overall. When we see so mechanical complications versus non-mechanical complications, what is their outcome? Of course, they have the high mortality, they have the high shock incidence, like 53%, most of them are in shock. Of course, the acute kidney injury, then the dialysis, the respiratory complications, they are high in this group of the patients. They are pretty sick, because if you see the cardiogenic shock is in 53% compared to any ST, which is ST elevated MI, which is just 8%. But in these complications, we see the very 53 of them are like very sick in shock state. So naturally, the other thingers mortality will be high. And if you see in this paper, 50% of these patients, which are around 10,000 patients, and 50% have been put on the mechanical circulatory support, which ranges from the IABP to MPLA to ventricular support device and ECMO. The same thing was in the non-STEMI group. They were the mortality was high in this group. The cardiogenic shock was high, 23%. Of course, the shock is less than the compared to STEMI, but it is there. So in the non-STEMI, you can have a shock state, like our 1/4 can have a shock state. And naturally, the other morbidity like kidney injuries, respiratory complications, and are high. And those, because of a shock state, they usually need 1/4 of them will need some sort of mechanical circulatory support. This paper, what we are discussing, is the latest one in 2019. This is a pretty busy slide, but I will just want to focus only a couple of things here. If you'll see, when you put an ECMO, it did not change anything. So ECMO is not something, put a patient and ECMO and you will have a good outcome, not at all. You will see higher hospital mortality was seen those patients who had the mechanical circulatory support. So basically, what I think is those are the sicker patients. You need an ECMO and any mechanical circulatory support in the sicker patient. So when you put a patient on IABP on ECMO or any VAD support or temporary mechanical support, it does not mean that you will have a less mortality and the outcome will be better. This was in STEMI. Similarly, in the non-STEMI, again, it did not help. The mechanical circulatory support, the ECMO did not help, though the IABP was better. So it varies from the group to group. So what is the summary of this paper? If you see the mechanical complications in STEMI at 0.2%, non-STEMI at 0.06%, still it is there. No change over the decade. In-hospital mortality is 42% STEMI. Those who have a complication is 18% in non-STEMI. No change over the 1 decade. Patient and mechanical complication, a higher rate of hospital mortality. They are high in cardiogenic shock, have more acute kidney injury, dialysis, respiratory complications. They have higher length of stay in the hospital. In hospital mortality is higher in the elderly people than both in the STEMI and non-STEMI. In hospital mortality is higher in the women compared to men in the STEMI, but we did not observe this in the non-STEMI. So mechanical circulatory support is pretty high in this group of patients. We put around 50% are in mechanical circulatory support in STEMI, and 25% people are in mechanical circulatory support in non-STEMI patients. So this was a good summary of this patient. I think it is a very interesting paper to read and know what is the current status of these complications. So now we'll focus on the ventricular septal rupture. Sometimes we it may be, you can call it ventricular septal defect or the post-MI, or some papers they write it a ventricular septal rupture. So this is our case. We had one patient who was 57 years old. He was male. He presented with acute anterior MI. It was a very fresh MI. It was just less than 1 day, 24 hours. He had a large anterior septal MI. This VSR was diagnosed. He was in shock state. He was ventilated, intubated, ventilated. He was on vasopressor inotropic support, anuria on furosemide infusion, and he was an IABP, which I didn't mention here. This is the case summary of one of our patients. We'll discuss the echo findings of this case in the coming slides. Then we'll discuss the operation of this patient and how he did post-op. At the end, we'll have a few slides about our KPMC experience in these VSR patients. So what is VSR? It is very simple. It is VSR is an opening in the ventricular septum, which is resulting from the rupture of an acutely infarcted myocardium. So what is the exclusively, what is the incidence of VSR now? As this paper, we discussed the first one. As we see, it is a 0.12% to 0.04% in the STEMI and non-STEMI respectively. The other registries and trials, the GRACE registry, it was reported at 0.26%. Apex AMI trial was 0.7%, Gusto trial 0.2%. Another New Jersey myocardial infarction data acquisition system database 0.27%. All the studies have shown it is like 0.1 to 0.2%, except the shock trial registry, where it was 3.9%. Actually, all of them were in shock. So whenever you have a shock state and a post-MI, your incidence will be higher than the routine MIs. So how did we reach this stage from, how did we learn? It's the first Latham who, it was the post-MI, this one, the VSD was discovered in the autopsy. Then in the 1923, the Braun, he clinical, it was diagnosed clinical, but nothing was done. Then it was the Cooley first who operated in 1957, a post-MI VSD 11 weeks after the myocardial infarction. I think the patient died 6 weeks later. At this stage, the approach was basically through the RV. So, and I think this patient died of pneumonia, if I remember correctly. Then gradually progressed the K and Dobust in 1969, the approach to the left ventricle. Then it was better. Then the double patch method came. Basically, Daggett, he did a lots of work on these patients. But his approach was he used to do an infarctectomy and a patch closure in 1977, and he reported a good results. Around his mortality was 37%. Then some people from the Japan, like Phil Juria, he approached to the right atrial approach, which is not so common, but has been done. This approach is particularly interesting when you have a chronic VSD. We just go through as a pediatric cases in the chronic post-MI VSD. I think David and colleagues, it is the most common, he did in 1987. He did patch closure, infarct, exclusion. This operation, we will discuss this operation in detail because this is the commonest operation done nowadays for post-MI VSRs, where the outcome is better than the infarctectomy. Percutaneous device closure or post-MI is still evolving. We'll have a few slides on this to summarize this, what is the percutaneous device closure outcome. So what is the natural history of post-MI VSR without surgical intervention? You will see nearly 25% of the patients will be dead by 24, in 1 day. They are pretty sick. 50% will be dead in 1 week, 60% in the 2 weeks, 80% by the 1 month. And by the 1 year, you will see the more than 90% of the patients they die. There have been the spontaneous closure of the post-infarction ventricular septal defects have been seen, have been reported, but it is quite very rare. And if you see this from the curriculum, this slide, if you see this is largest series, 139 patients in 1978. Earlier the mortality is very high. By the 1 month, most of the patients are dead, 80%. Then those who survive, they may stay in heart failure, most of them, but they may make to 1 or 2 years or even spontaneous closure if they are very tiny. So only those survive who have a small defect. What is the timing? When does the VSR happen? There are the few trials, you can diagnose the VSR has been diagnosed in usually within 24 hours. It was diagnosed in shock trial, Gusto trial, and another MXMI trial, it was diagnosed within 24 hours. But if you see the historical data, pre-thrombolytic era, it was diagnosed a few days, 3 to 5 days. But you may diagnose, even some people are very, you may miss the diagnosis. They are very stable even after 2 weeks or even later. You may diagnose. So there is some people say it is a bimodal presentation. They say early and the late. Basically, sometimes we miss, we don't pay attention to small defects and we miss them sometimes. So what is the pathophysiology of VSR? Morphologically, we classify them into simple defects and a complex. What is simple defect is it is a direct connection between the left and the right ventricle at the same level of the both chambers. But sometimes we have a complex ruptures. It takes it takes a curved course, or there is a dissection in the septum, and we call it serpiginous course, and it is caused by the hemorrhage and irregular tears within the necrotic septum. This picture is one of our patients who presented with an acute MI and had a dissection in the septum. So you can whole septum can be hemorrhagic and have the necrosis, and there may be a long dissection path within the septum. So what happens then? Whenever you have a defect, you get a shunting. The oxygenated blood, it is from the high pressure left ventricle goes into the right ventricle, and from when the both chambers, they have a biventricular failure and eventually cardiogenic shock, and then the consequence of cardiogenic shock, as you know, followed by the multi-organ failure and eventually the death. This classification, Becker and Mantgem classification, is basically from the perival rupture. But since the pathophysiology is same, so this classification can be applied on the VSR as well as per the pathophysiological point of view. So type 1 rupture, there's an abrupt tear in the wall without any thinning. The type 2, he classified as infarcted myocardium erodes before rupture occurs, and it is covered by a thrombus. The third type is, there is a thinning of the myocardium, secondary formation of an aneurysm, and eventually the perforation in this aneurysm, and VSR happens. So these patients types are usually stable. Type 2, they are subacute stage, and the type 1, they are usually in the cardiogenic shock. So what leads to most common risk factors? Most of them, 50% of them have a single vessel disease. It is not seen in the triple vessel disease, less common. But single vessel is a commonness, is a risk factor. So we'll see in the literature, more than 50% people have a single vessel disease. Usually the MI is big. It is usually seen, as we have seen the first paper, what we described, it is most common in the STEMI. There's more myocardial damage. You don't have a collateral circulation. If you have collateral circulation, they have less common. That is why if you have chronic ischemic heart disease, they don't develop. So there is a poor septal collateral and they perforate. So which territories are? So LAD and right coronaries are the most common infarct-related arteries leading to septal rupture. If you see that in shock trial, it was in 42% was LAD and 46 was the right coronary artery. Anterior and inferior infarctions contribute roughly equally in both VSRs. So you will see anterior and post-infarctions are almost the 50-50. But there is a good amount of literature where I have seen the anterior infarctions are more common than the inferior infarctions. Anterior infarction, in our series in KFMC also, we saw most of the cases were in anterior infarction. You will see there's the patients who have a hypertension, long-standing hypertension, who have diabetes, have a prior smoking history or prior MI. It has been shown they have the less VSR. I don't know the reason apparently why. Maybe they have the chronic underlying disease which leads to the development of the collaterals, and that is why they have the less. But in our series in KFMC, we noticed diabetes and smoking, hypertension was present in 50% of the patients. So equally important is these patients, those diabetic, they are more sick. This may be the bias. This may be observational bias as well. So how do they present? It could be presentation, could be just as dyspnea, a mild dyspnea as we see, or they may be not much in heart failure, and it could go up to the severe cardiogenic shock and multi-organ failure. So there is a very wide presentation. So you have to keep this diagnosis in mind when you diagnose in any patient who has an acute MI. One of the important features in clinical is a cardiac murmur. You will almost every patient you will see this murmur. It is very harsh, it is loud, it is hollow systolic, and it is heard all over the chest, and it is widespread. So every patient you should put a stethoscope and listen to this murmur. Any patient who has an MI, even though he's very stable, you may miss sometimes. Clinically you may pick up. So then starts the right heart failure, left heart failure. So you can see this gallops because of the heart failure, and then you can see because of there is a high flow in the RV and the high flow in the pulmonary system. The P2 may be loud, and one of the important is you should differentiate it from the mitral regurgitation murmur. And sometimes clinically it may be difficult. So the scenario may overlap, and patient may have even there may be associated mitral regurgitation. So diagnosing a murmur does not mean it is a VSR. It may be other valvular lesion, particularly the mitral regurgitation. So, but what only it is the echo which will help us to differentiate between the two. And the two may have coincide. They may be present in the same patient with VSR with an associated mitral regurgitation. So I think this is how the clinical physical features of cardiogenic shock. Everybody is familiar with it. If you have you have cold periphery, cyanosis, orthopnea, delayed capillary refill, and the lungs are congested because of the left heart failure, you will get a pulmonary edema, you may get cracklers, you may have displaced cardiac apex, you may have left-sided heart murmurs. And similarly, in the right-sided, you have the edema, you have increased JVP, you have the murmur of tricuspid valve area. How do we diagnose? The X-ray test is non-specific. It won't help. It will just show the congestion of the lungs. ECG is non-specific. The most important diagnostic tool, what we have, the echocardiography, both TE and transthoracic and transesophageal. And the pulmonary artery catheter, it will also help in diagnosis, but it is not a must. Of course, the coronary angiography should be done in such patients. And in the cath lab, you can do left ventriculography, and we can diagnose with the left ventriculography. We can diagnose with the shunt there, dye can cross. And sometimes, very rarely, we may need a CT or MRI, some cases to establish the diagnosis when we have problem with the echo. As I said, the X-ray, it just shows a pulmonary congestion and pulmonary edema. ECG does not show anything specific to the VSR, but it will show the MI, it will show the ST changes, or in the late case, persistent ST, the LV aneurysm. Sometimes in a VSR present is late. If you present is third week, you will see the LV aneurysm associated, and you may have still after 2-3 weeks ST elevation. But the cardiac enzymes will be almost normalized by that time. So ECG and X-ray is not specific to it. The most important tool is, as I said, is the echo, both transthoracic and TEE. It gives an accurate information in terms of the location and size of the septal defect. Associated ventricular wall motion abnormalities can be diagnosed. Mitral regression, tricuspid regression can be quantified. Assessment of the left ventricular, right ventricular size and contractility. So this is the most important tool where we diagnose and start our management point of view. So sometimes transthoracic views are not accurate, or we need, you may miss sometimes the LV thrombus or other information. That is why we might need a TEE. This is the case, the case summary we presented before. This is the case where we have, this is a short axis, and we have the drop here, echo drop here. And then we can see a large shunt which is crossing across. And you can see here, this is the same, the video where we see a large shunt crossing here. Again, the short view of the same patient where we can appreciate the big defect. Sometimes, as we have seen, this is one of our, not this case, is another patient who I showed this image before as well, where the TE, where we see a serpentine course, whole septum was necrotic and was dissected. This is one of our patients, he had a large septal defect, and, you can see that this was hugging. It was difficult to appreciate, then we did it, and we could appreciate there was a large shunt across the defect. If you appreciate here, if you see the defect is here, it is not that big, but when we did a TE, it was showing large in other views which I have not seen. But if you see the RV is good, so it is not every patient will be sick. This patient was stable. He presented late presentation, and his RV was good. But if you see the LV is hardly moving. So this present, I remember it was around second or third week, and he had a huge LV aneurysm, and his ejection fraction was around 15 to 20%, but he was stable. So what we did, we put an IABP as a routine, which is not must, but we just put it. And then we'll show the pictures, operative pictures of this patient, but he was quite stable. So Swan-Ganz is catheter. It is not must, but sometimes we put it. It is not the patient may be stable, and even a cardiogenic shock, it is not something highly recommended. But it is, some centers have a practice of putting it and measure. It may be introduced at bedside or in the cath lab. It will reveal a step of oxygen saturation in the RV, and we can calculate what is the shunt. We can also see the wedge pressure and left atrial pressure and left endostolic pressure. That will help us in the patient management also. And these pulmonary pressures are usually elevated because of the high flow, and the LV is also is very weak in these patients, and the backflow LA pressure is high, so it is a back pressure is high. So every coronary angiography in patients undergoing surgery, it is it's highly recommended. Coronary angiography should be performed in these patients. In case of severe coronary artery disease, additional coronary artery bypass grafting is class 1 recommendation. We should perform the cabbage with these patients when we take them for the surgery. And occasionally in the cardiac catheterization laboratory, we do, when we do angiography, coronary angiography, we do a ventriculography as well, which confirms the presence of VSR. So it may be the ventricular receptor, it may be associated with multiple coronary artery disease, which have been reported in several, in papers published. But there is a high prevalence of the single vessel disease. As you said, around 50% they can have a just single vessel disease. And even, but most of the time, these patients have a total occlusion of the infarct-related arteries. I have hardly seen any, patent artery. Most of them, they are totally occluded. So management point of view, we have medical management. I think we will not discuss this part of it. It is a cardiology business, or, it is a routine. Any medical management is routine for every patient. Mechanical circulatory support, sometimes we need a perioperatively. It depends on what is available in your heart center and the practice, the local practice in the center. It could be from IABP to Ampilla to tandem heart, or even the ECMO. Some patients may be put on ECMO. Only the case series have been, there is no big series. So it is only a few case series experience of these support devices. As we have seen in the paper, the first paper, there is hardly outcome does not change. So surgical repair will be our main focus, how we approach them and how we fix them, the infarct exclusion technique. And the management is also, some patients may be fit for the percutaneous device closure, and which is evolving in these cases. So when should we operate this patient? There is still no consensus. Every center and every surgeon, it is an individual decision. Although the surgical mortality remains very high, but non-surgical mortality even higher. Most of the 90% die. So only hope is the surgery. The clinician must weigh the known risk of surgery against the unknown risk of postponing the surgery and developing further clinical deterioration. So what does the guideline say? If you say the AHA guidelines, ventricular septal rupture after STEMI, It is a class 1 indication to take this patient is complicated by development VSR should be considered for urgent cardiac surgical repair unless you think that further support is considered futile or the patient wishes or there is contraindication. Otherwise, you should take them immediately to the surgery. And also the cabbage should be undertaken with when you fix the VSR is a class 1 indication. In 2013, the AHS stand with the same guideline. Emergency surgical repair is necessary even in hemodynamically stable patients because the rupture site can expand abruptly and result in sudden hemodynamic collapse in a previously stable patient. So AHS still stands that we should take these patients immediately after in a reasonable period. But if you see the European Society, they say that early surgery should be performed all patients with severe heart failure that does not respond rapidly to aggressive medical therapy. However, delayed surgical repair may be considered in patients who respond well to aggressive heart failure therapy. So if the patient is sick, take him to the OR. If the patient is stable, he is rock stable, then better to wait because your outcome will be much better. As we'll see in the coming slides, we'll see what is the outcome depending on the timing of surgery. This is very, very important to understand the timing of surgery. If you see this slide, 30-day mortality in VSR patients, immediate surgical management. If you operate within 24 hours, the STS data shows a 60% mortality. And if you do a percutaneous, first couple of days, it shows an 88% mortality. If surgery is done after between first week, a gastro trial showed 47% mortality. STS, if you do surgery between 1 to 7 days, it shows a 54%. And percutaneous, if you do up to 2 weeks, the mortality comes down to 38%. So if you keep on waiting, by the 3rd week, now here we are in the 3rd week, mortality comes down 30. It was 60, then 54, then 30. And eventually, if you go by more than 3rd week, the mortality comes 10%. But problem is, surgery deferred, unknown percent of mortality while waiting the intervention. We don't know how many patients died during this waiting period. Because when the patient is elderly, he has multiple comorbidities, he has a multiple organ failure, then hardly the surgeon is not willing to take him because he thinks, and the family is not giving the high risk consent. So most of the patient is died. But if your patient remains stable by 2 to 3 weeks, your mortality will be less than 10%. In this gastro trial, those patients who waited from the acute MI up to the here, 94% of the patients just died. No attempt at surgery. The most in 30 days, 94% died. There are some patients where we need a full mechanical support like ECMO, tandem heart, LVAD, but this is unknown, because the only case reports have been are there in the literature. I also suggest to read this paper, very interesting paper. I think we know now if you have an acute MI with VSR, we have the option as hemodynamically unstable patients. Either you better take them immediate surgery if they are surgical. Some people may think of, there is a practice of putting them ECMO and delaying the surgery till they are stable. So only case series, so we are not sure. Some people may not be surgical candidates and they may go for percutaneous closure if the anatomy is suitable and they are unlikely surgical candidates in the future. If patient is hemodynamically stable with a large VSR, you should very closely monitor and put him, some recommend put him on IBP, some sort of mechanical circulatory support and delay the surgery, which I have a different approach. I don't, if you have a large VSR, you better take him. If he's stable, better take him. This is my opinion. Better take him the surgery before he deteriorates and becomes the multi-organ dysfunction. If you're hemodynamically stable, like small VSR, it doesn't matter. So you can delay surgery easily. You can put him on conservative. You can do percutaneous closure after 1 month or 3 weeks or whatever, and elective surgery. But this is only a very small VSR. But in the large VSR, my suggestion is if you have a hemodynamic stable large VSR, better take him early before he deteriorates. Unstable patient is my opinion, like immediate surgery better before he develops multi-organ failure. But if the patient present is late, already established multi-organ failure, then I recommend we should delay the surgery, put him on some mechanical circulatory support. And if he recovers, if he starts recovering, then go for surgery. If not, then we have to continue with conservative management.
Dr. Shabir?
Yes, please go ahead.
This is Ayat. I am R2. Regarding the size of the VSR we have, is it, it will differ? I mean, small, how much small?
See, if you, there is no, like, it depends on the, like, if you are 1.5 centimeter is taken as less than 1 is taken as a, is not as a small, but it is fit for the percutaneous closure. So if you have a very small jet, if you see an echo, jet is small, patient is rock stable, he is not in shortness of breath, he is not on any support, he doesn't develop any lung congestion, you follow echo 2-3 days, his LV is okay, his RV is okay, and you appreciate there is a jet which is not a huge one. This we can clinical grounds, you can say this is a small, and you can wait such patients. He is walking around the floor. Now the another patient, he has a jet, it is a little bit large, but he's not doing, he has a lung congestion, he start his lungs start wet, he started, borderline BPs. I think whatever the shunt is there, you should take him for the surgery. So it is not that somebody will tell you it is 0.5 and we should not do surgery, or we should conserve it. It is a clinical, you have to correlate with the clinical grounds. So the depends on the size is not an exclusively to manage the conservative management. It is a clinical scenario, how the patient is behaving. So less than 1.5 centimeters fit for the device, more than 1.5 is unlikely fit for the device, but it has been done. So sure. Sizing is important for the percutaneous or this one or surgical point of view, but for clinical grounds, you have to correlate the size with the clinical scenario.
Okay, thank you.
Clear? So size is not an exclusive. You will say the size, the cardiologist reported, 0.5, it has no meaning if the patient is not doing clinically well. Okay.
Okay.
So surgical techniques, as there are many, everybody modifies this. There is no consensus what surgical technique you should apply. But overall, these are the common techniques, Daggett technique and the David technique. So what Daggett does, he puts a single or double patch technique, which closes the VSR by placing a patch over the defect. After he does an infarctectomy and sewing the patch to the RV and the LV. So here you have to, he enlarges the VSD and then fixes it. In David, what I think this, which we advocate, this infarct exclusion, we do not touch the infarction at all. So whatever the patch is, it is exclusively to the LV side. And we stitch the patch to the healthy myocardium, not to the infarct part. We'll go in more details. So if you see what is the general principles of the infarctectomy post VSR is, you trim the left ventricular margins and the septal margins, and then close the defect without a tension with a patch, which could be pericardium or a Dacron patch or bovine or the autologous pericardium, and then buttressing the suture line with pledgets of Teflon strips without cutting through. So if you see here, this image, this is the inferior margin. He put a pledget on this side and then another pledget on this side. So there is a pledget on the RV side. There is a pledget on the LV side of the septum. Then he finishes this. Then he comes on the anteriorly. He puts a pledget on the patch and then comes out to the RV here or an LV edge. Mostly it is an RV. So you basically do an infarctectomy and then do a patch. But the problem here is most of the time, it is an infarction. So it is difficult to judge the healthy myocardium in an acute setting. So, but this infarctectomy procedure has been reported by the Daggett, and he showed a good results. His mortality was, in his paper, was around 37%. Another more familiar is a infarct exclusion method, where we don't touch any necrotic tissue. We don't do anything. We leave the infarction as it is. So we put a pericardial patch sutured with continuous proline around the defect to exclude it from the LV cavity. Then we do a full thickness bites are taken to the epicardial surface and anchored by strips of pericardium or Teflon. Then anterior patch is anchored to the non-infarcted septum below the defect and then to the non-infarcted anterolateral ventricular wall. Then fifth step, posterior patches are anchored to the mitral annulus, non-infarcted septum, and then to the posterior wall along the medial margin of the posterior papillary muscle. And then we close the infarctectomy using the strips of pericardium or Teflon. And infarcted right ventricular free wall is left undisturbed. We do not touch the right ventricle at all. We'll go through details of this procedure. So how I do it? So I usually do the infarct exclusion technique. So first I put a cardiopulmonary bypass. I would have bicaval cannulation because there is a large VSD. So you have to put a bicaval cannulation. Then we drop a temperature to just 30 or 28 or 32, around 32. Then we give a usually integrated cold blood cardioplasia in our center. I put a vent through the right superior pulmonary vein. And if I have to do the anastomosis, I prefer to do the distal anastomosis before I touch the VSR. Then second step is I do a left ventriculotomy incision, which I put parallel to away from the LAD 1 to 2 centimeter away from that one. And you should do this ventriculotomy very wide, don't hesitate, because most of it is infarction. So it is almost distal 2/3 of the anterior wall. I put an incision. So I open widely so that you get a good exposure. This is already infarcted, so it doesn't contribute anything to the LV function. Then I put a 2 sutures and retraction sutures, which help in the exposure of which aid in the exposure of the septum. The next, I take a bovine pericardial patch. I take a big patch, which is available. This is 10 by 5 centimeter. I always take a big patch, then tailor it to the shape of infarction. Usually it is, oval or circular in case of it is usually an oval in case of the anterior, maybe some more triangular or D-shaped in case of the posterior inferior VSR. And then patch is then stitched to the healthy endocardium and healthy myocardium away from the edge of the infarction. So do not go to the necrotic. I usually use a trioproline suture. In this, when we put a retraction sutures, then you can see this is an acute infarction. We were discussing this case summary, the same patient. We showed the case summary, then we showed an echo. And this is the intraoperative same patient where we see a large anterior septal, ventricular septal defect. Then we fix it. So we start the continuous sutures from the posterior inferior part of the healthy septum with wide bites. So we start very deep. We go in the deep and start a continuous sutures. Don't pull too hard because it is a muscle. It may cut through. And I reinforce these sutures with the pledged sutures. I put a first continuous, then I put, if you can see, this is a pledged sutures. I reinforce with these pledged sutures. Then when you reach the anteriorly, I bring the sutures out. And in the apex also, this is the apex and this is the proximal. So I bring the sutures out, I bring the suture out here. Next, I suture. Now, if you can see this image, this is the patch. I stitch this patch from the inside to the anterolateral wall of the ventricle. So this is the right ventricle. This is the LAD area. This is the apex, and this is the proximal. So I stitch these, put stitches from inner to the out on the anterolateral. Basically, this whole is, this part is all dead. But you take some part of the healthy myocardium so that it can hold your sutures. So patch is then sutured to the anterolateral wall with sutures or exteriorizer and buttressed with Teflon. Make sure the patch is not under tension. Don't put it. Usually a bit of redundancy is better. Why? Because it avoids tension and tearing of the patch, and it also will help the filling of the LV during the diastole. You will see this case, we'll see the post-op echo of this case, how the redundant is and how it helps us in the filling also. Then we close the ventriculotomy is closed in 2 layers, over and 2 strips of Teflon. I use a 2 polypropylene sutures, the big needle, and you are done. This is the patient what we were showing the case. This is a pericardial, how it looks like. This is a pericardial patch, this is the LV, and this is an RV. If you see this echo, you can see this how redundant, It is. But when there's a diastole, it pushes and the LV cavity is good size, but it keeps on moving. So when the echo was done in this case, the cardiologist reported this is all, it is your patch has gone and it is dehiscence all the patch. So which was not that true. So what happens is the same case, you will see the patch here, and the septum is all necrosis. So there is a big shunt, but the shunt cannot cross this one. So shunt is stopped by this patch. Basically, if you pay attention, there is hardly any flow across. This patch does not allow the patch, but the cardiologist reported, dehiscence, and then in this case, we have to do MRI, and then MRI confirmed there is no shunt basically. This is one of our patients, we did a case report. He had a large ventricular septal defect, and he has a large, ASD as well. I have not seen any case like this, but it was a very interesting case. He had a large VSD, he has a large septum. This patient was basically very stable. You know why? That is why we did a case report. Actually, the large septum, because of the large septum, his RV was, hypertrophic, it was large. So it could tolerate the pressure load from the VSR. So it was, it was trained before because of the large volume from the. Then we fixed his VSR, we fixed his ASD with a patch, and you can see there is a defect before. This is another patient, one of our patients, I was showing that he had a severe LV dysfunction, ejection fraction was around 15-20%, but he was quite stable. And RV was very good, pretty good. So, but we put an IABP just as a routine. Sometimes we do it. And he has a large aneurysm in the anterolateral wall. The cardiologist took him to the cath lab. He said, this is a chronic, let me try, put a percutaneous closure. He spent a couple of hours, tried to cross the wire. He couldn't do it. And then at the end, I took him from the cath lab to the OR. When we opened it whole, you can see it was a serpentine, basically. As I said, the dissection was whole. So it is difficult to cross the wire directly. So that is why he was failing to cross the wire from the LV side. Usually the wire is passed through the LV through the defect to the RV. But he was not able because of the course was very, very curved course and serpentine course. So what we did, we put a patch, we put a big patch, and then we put this, the anterolateral, we excised the most of this, the aneurysm part of it. And this is the end stage, very horrible picture, but but this was just aneurysmal. This doesn't mean anything, but you can see this is LV, but looks a very awkward picture. I will show you, I have done a small video of this, how I do it. This is the same, one of our patients, I think the same patient what we discussed. We made the same case. So sick patient, cardiogenic shock, intubated, large VSR, you can see the anterior septal, ventricular septal rupture. Then took him to the OR as an emergency and do the bicol cannulation and cardioplegia. If you can see there is it is an acute MI. You can see, there is hemorrhagic spots, and it is very, very fresh MI. I think it was in 24 hours or so. Then we started, opening this is the LAD area. This is the head of the patient. This is the apex. So we did a large ventriculotomy. You can see, you should not be hesitant. You should open widely because the most of it is dead tissue. So it does not contribute anything, rather than it will later on become an aneurysm. So better you should bring this necrotic part out of the normal LV cavity to prevent the future LV aneurysm formation as well. So we put a retraction sutures. So this is the retraction sutures. So then after retraction sutures, you can see this VSD is very nicely seen here. And it helps us in, it is in the anterior, the basal of the septum looks healthy. Then put a stitches as I have shown. Now we have the cavity. This is outside the LV. This is on the RV side now. So you have three cavities, RV, then this cavity, and the LV cavity. This is the patch, stitching from inside, and these stitches will be going to the outside. So RV, then this cavity is the second cavity, and the third cavity is the LV cavity. So this is LV, this is the new cavity, and then is the RV. So this is the final picture. So what is the current literature about this outcome of this patient? So this is a very interesting paper. I think, I recommend you should go. This has been by Tyrone David. He is he did this infarct exclusion technique, and he did a 44 patients. And this paper, by the way, was in 1995, long back. 44 patients, and 29 of these patients were in cardiogenic shock, a good chunk. And he had only 6 operative mortality, 14%. Even in current era, I have hardly seen having such a good results. And his survival, if you see, is 6 year survival is around 66%, very remarkable. So what he did an exclusion, the same what we described in our technique, did an infarct exclusion. But if you see this cross-sectional area, you put a stitch here, septum, healthy septum, and I tried this stitch, from inside, it usually cuts through. So what I do, I put a pledget here and bring the stitch out and tie it outside. So with this, your cut through chances are very less. That is the only difference. I modified it a little bit my own way. I have done some cases. So, but if you do inside, it just cuts through, because this is just a muscle. It hardly holds. So this is another, recently published in 2019. They just modified this exclusion technique. What they did, they put 2 patches. They put 1 patch here and connected to the RV side. Then the second patch is connected to the first patch, and then they joined double patch. One day they said, the residual defect is less. I don't know any advantage personally. I am not sure whether it will help or not. This is a shock trial registry. Everybody, I am sure, a shock trial was there, where there was early revascularization versus the medical treatment. The early revascularization was good than the medical treatment. But this is a shock trial registry. It is not a shock trial. So in this, around 939 patients were enrolled in shock trial registry, and 55 patients had an VSR. So, but they were in shock. That is why the incidence of this in VSR in this shock trial registry was 3.9. So, and the diagnosis of this rupture was made within first day, within 24 hours. The median was 16 hours. So what they saw it, those who were medically managed, they had 87% mortality compared to 61% mortality, those who were managed with the surgery. But surgical repair was performed not in 55%, only 31. And only 96 survived. Out of 31, 25 died. So survival with the surgery was even dismal, 19%. But even the survival more dismal with the medical management, 24 patients, they were only 1 survived. So there is almost a 99% mortality, 96% mortality with the medical treatment. But here it was at least, it was 80% with the surgery. This paper is a national experience from Sweden, a good number of patients. It was in 2005. They did a good number of patients. 189 patients. I think these are one of the largest series from National Registry. They again, if you see the mortality, the 77 of 189 patients has died, which 41% mortality. And 5-year survival was just it was 38% at the 5 years. But what was interesting was in this paper was, if you do a surgery early, as we described before, the mortality will be high, 67%. The more you wait, the more you wait, the less the mortality. So my suggestion is, if the patient is rock stable and has no issues, better to wait. But if the patient you think is like, it's a large defect and he may deteriorate, to take him to the OR. But if the patient is stable, better wait. This paper in 2009 had showed a 25-year period with 102 patients, a good number of patients, showed an overall mortality of 33%. It was in early era, first era, it was 45%. Then they improved in the second part of the study. It was lesser mortality. It was just 21%. This is an important paper on, I think I also suggested this is a, STS database paper, where it is around, from 1990 to 2000, more than a decade data, which has a 2,876 patients. In this STS data, if you'll see from over 1 decade, the number of procedures were static. They were up and down, but they were all the time more than 200 in each year. The data in the 2010 was not complete. Then what was the mortality? If you see, there is high, but overall, if you see in the STS data, the mortality is 40% overall. So overall mortality is 40%, right? But if you see if you operate less than 6 hours, you can see the mortality. Then within 1 day, within 1 week, within 3 weeks, and after 3 weeks, drastically improvement. So, but while waiting, you may lose patients. So this is a bias, this is just a different center, so it may be biased. They found following risk factors for operative mortality in STS data. They showed an age, elderly people, female gender, those who are in shock, imperial infarction, they're difficult, technically difficult, very difficult. And pro-operative, if you have an intra-aortic balloon, it was showing a more mortality. Probably the patients were sick. Those who were before on dialysis have an associated MI and a redo, emergency, and most important, timing of surgery. This will decide your outcome. I think this is another paper, they described 21 patient. Only thing is they did a triple patch. One patch was first was to the septum, second was from the septum, and the third was to the healthy, then joined the 2 patches and put a glue. I don't know any advantage of this technique, but it has been reported. This paper in 2017, it was in Brazilian cardiovascular surgery. They did a 55 patients, 40 patients operated. The death was more than this, 21 died. That they reported a 52% mortality. Only 19 survived. Elective device closure, all survived. Basically, this is how the bias comes. They are very small. They do one. They are not sick. They do after a couple of weeks or 1 month. They have to survive. And those who are not operated, they just died. This is another reason in 2018, they did around 39 patients, and went to anterior was 54 and posterior almost, anterior a little bit more than the posterior, but was not statistically significant. They showed a 31% mortality, and important in the mortality outcome was those who had cabbage association. They did better than where we did not do the cabbage. I think we did this slide. So recurrent ventricular septal defects, there is a recurrence because of the necrosis. You may have the defect, stitches may go, there may deficiency of pad. It has been reported. Most of the series 10 to 25%, but even you will see the papers who say 3 or 0 or even 35. I have seen some papers, but this is overall average recurrence rate. Large residual, what should we do with them? If they are large, they should better to redo them. If small defects, Most of them are manageable by the spontaneous closure. They may, sorry, by the percutaneous closure, or there has been a report of spontaneous closure. If they are not hemodynamically significant, very tiny jet, I think just leave them alone. And even if they are late coming, let's say a couple of months or even more, you can do this right atrial approach as we do in case of the pediatric VSD cases. What is the percutaneous general principles of the device closure percutaneous? Most authors suggest that a defect of less than 15 mm is optimal because of the device sizes, but you will see the case reports, even the bigger defects have been done, and the size of the septum. Then inferior and post-infarctors are very difficult because there is no rim, there is a tricuspid valve is in nearby, mitral valve is nearby, so you may have difficulty in percutaneous device closure in case of the inferior posterior defects. You know, as we have one of our cases, they tried a percutaneous closure, it didn't happen because of when you have the curved course, it may be difficult to cross the wires. So, and freshly infarcted myocardium, you know, failure rates are very high. You don't know what is the extent of the necrosis. So there may be leakage and the device may embolize in the fresh MI cases. In this paper, you can see there is a major trial is a percutaneous closure of VSR. You can go through this paper, but I just want to pay your attention on a few things. You know, timing of device closure is very important. If you go to the third one, cardiogenic shock 16, okay, they did an early 1 to 3 days, see 88% mortality. So here they have, here in device closure, there is always a selection bias. So if you, when you read this slide in depth, go through this paper, you will come to know that the more early you try to fix there will be the high mortality. And there is, of course, there is a selection bias in these cases. So what is post-myocardial ventricular septal is rare, but it is a potentially fatal complication. Surgical correction carries highest mortality among all cardiac surgical procedures. Clinical presentation predicts the outcomes, and treatment strategy should be individualized. You cannot fix in one parameter and one protocol according to the patient's clinical status and hemodynamics. And a successful surgical outcome depends on the prompt recognition. You should be very cautious, and you should have in your mind about this possible complication. If you are interested, I can present our outcome in our KFMC, what we did. We did so far 12 cases. We have these, as I said, hypertension, smoking, and diabetes, you know, predominant. But in the literature, you will see they are usually non-risk factors. But in our group, we saw they were the risk factors. 50% of the patients had these issues, and there was no history of prior MI. Sorry, this is an error here. And this apical and anterior, they were almost 10, and only 2 cases were posterior. And simple, and it through and through was 9, and the serpentine were the 3 cases. And most of them, okay, single vessel was 6, you know, 50% of our cases had a single vessel disease, multivessel was only 6. Most of them were in, you know, were in heart failure, 50% cardiogenic shock, there was no arrest. IABP was used around 58%, no ECMO was used, and inotropes were also highly used. So urgent surgery was done in 4 patients, emergency in 5 patients, salvage was in 3 patients. And I think this is not important. And yeah, you do cabbage, no, almost 6 patients where we did an cabbage, maybe single graft, 2 graft, or 3 graft. 1 patient, as I showed, we removed, and 2 patients we removed an associated aneurysm. And then 4 patients died, to be honest. So there is we have a 33% mortality, 77% are surviving. The heart failure, low output, multi-organ dysfunction, sepsis was the cause of mortality. We have a 25% residual cases, but none of them need an intervention because it was a very tiny defect. And we are working on this caution study. It is a multi-center study, which is with the European centers. Data has been already collected, and you will see soon this in the publication, maybe another few months. Thank you very much. Hello. Any questions?
Dr. Shabir, if you allow me, this is Dr. Shabir. I'm fixed in Faisal Hospital. Doctor, you mentioned earlier in your presentation that there is some increase on incidence of VSR recently. So do you think this is has something to do with our management, or maybe it's better detection that we have?
No, to be honest, if you see the first paper, that is why I presented that paper, if you see the prehistorical era, it was 1 to 2%. Definitely it is less. If you pre-thrombolytic era, it was high, 1 to 2%. In shock, it is around 3-4%. But last 1 decade, with the paper what was in, that I presented, and it is 0.2, the most of the registries from last 1 decade did not show any improvement. It improved compared to pre-thrombolytic era, where it was very common. Now it is not that common, but it is static. Why is it static? Because our PCI and our thrombolytic therapy is same. I don't think there is much improvement, and it depends on how much disease it is, So there is no definite reason. No, the MI, it has nothing to management. The VSR happens, it happens. So it is not but we can improve the outcome. I mean, VSR, we may improve. I'm not sure if we manage them very early presentation, if we do not lose them, do a PCI very early, there is chances we may get a better in incidence. That is true. But what is the most important is the outcome. It is still a 30-40% mortality in these cases. We have not. We can improve in the management point of view. I agree with you, but still a lot to go to improve our management.
So, Doctor, another question. Did you find any difference in your practice between the posterior infarct and anterior in terms of outcome and mortality?
Yeah, to be honest with my colleagues, did a posterior. I didn't get a chance to operate a posterior one. But I have assisted a couple of them. They are really tricky, and the anatomy is very difficult. But I have not done personally posterior. I did personally, I did 7 cases. I lost 1 patient. I was a 90 years old. The operation went okay. He was, everything was fine, but his systems were, 90 years. He eventually died after a few days, but I don't know the reason, to be honest with. Not definitely we did his post-op echo. There was no residual shunt. LVRV was fine, but we lost him. But to be honest with, technically speaking, anterior VSDs are much easier. And personally, I don't, if the patient has a good systems like, his kidneys, his liver is fine, he's stable, better do not wait. Because why? Because you are doing infarct exclusion technique. So I personally feel you should just take them. Don't sit on them, just go ahead and fix it. Yeah. Of course, if you have a patient who has a VSR after he comes to your hospital 2-3 weeks, it is, and he's stable, it is just a piece of cake. You don't worry about it.
Okay, thank you.
Dr. Shabir, if you allow me, I have 2 questions. The first one, do you prefer taking patient immediately to surgery or put this patient with cardiogenic shock on ECMO and wait for a few days, then operate on them? The second question, in guidelines, they mention if patient present with the septic shock and, cardiogenic shock and with multiple organ dysfunction, we should wait of them, then we look to the parameters to see if they will get benefit for the surgery or not. So what's the criteria to take patient with multiple organ dysfunction after cardiogenic shock?
Okay, so it is individual decision. Let us make a scenario. We have a patient who is 60 or 70 years old. He has a large VSD. He is stable. Kidneys are okay, but his borderline blood pressure is lactate is little bit higher. Now he is large. What I will do it. I will go and operate upon him. No waiting. Now you give me another scenario. Let us what you are telling me. You have a patient who is elderly, has a multi-organ dysfunction, as you said, has his liver is gone, the INR is high, and his kidney he is not getting. Now you start on dialysis or renal replacement therapy, or no, I will not take him to war. So it is individual decision. Don't rush to the patient. Every patient you have to individualize and see what you can do. Guideline, as you said. You know, even the AHA guidance still said, no, you should better to take them early before they deteriorate and certainly deteriorate. You know, and suppose 7 p.m. the patient is stable and you know, now she start deteriorating. You got a call at 7 p.m. the patient's lactate is 5 and he is a little bit near more oxygen, his breathing is, don't sit till morning. Morning you 12 hours, the patient will be in shock. So definitely your morbidity more. So I will go and arrange an OR and do it. But you get a call 7 o'clock, they received a patient who is, you know, has already the liver is very high, 1000, his INR is 3, and he's not making urine, and no, I will refuse to take this patient to the OR. So what should we do? As you said, you know, there has been some reports where we put an ECMO, has been put another Ampella or Tandem, there are some case series. Yes, we can try with that, but rushing this patient directly to the OR is a mortality. So we have done these cases. I can give some case report. We had one patient, he was stable. They put an ECMO over weekend. The cardiologist removed this, not ECMO, sorry, IABP. We didn't have any patient on ECMO. He started deteriorating. Then they called me, this patient was stable, but we removed ECMO. After 12 hours, he started deteriorating. I went to and took him to the OR because before he gets some multi-organ and starts the advanced irreversible, you know, things, irreversible cardiogenic shock, you should take them. So you have to be careful. There is nothing one protocol which fixes here. So every patient is individual. If you want, one of the papers I didn't present it, he was, you know, I can send it in the group. It is an elderly patient, is more than 75 years age, and they had a VSR. You know, the operation rate was only 17%, 17. Maybe the reason was like multi-organ failure, elderly, the family is not ready, surgeon is not happy to take them. So more the elderly paper, you should be careful. Number two, more multi-organ failure, you should be careful. So it is a very important prompt decision, and I think every case is different. You cannot fix it in one basket. But you know, but if you see the European society, they say they have now, they are a little bit lenient. If stable, you can wait. If the patient is, you know, in difficulty, then better to take him to the OR.
In any circumstances, you used for any of those patients Lima, or you will use all vein graft?
I have done, as I said, 7. None of them I could do a graft of LAD because, as I said, most of them have a total occlusion, and all the anterior wall distal is gone. It is necrotic. So there is no fun of, you know, this one. So when you open the LV, this is all necrotic. Don't worry, because this is not contributing any function now. Rather, you are helping the patient, because otherwise this later on it will become aneurysmal. So what you open it, you take the LAD, you know, LAD area is gone with it. Yes, I have done the diagonal, I have done the PDA, I have done the other graft, but not the LAD.
Thank you.
Any other questions?
Yes, doctor, thank you for this presentation. I'm just asking, you mentioned in a patient with recurrence or patient or late presentation, you can go the transseptal approach. Can you please elaborate more on that?
Oh, late presentation. Yeah, late. Suppose if you have a like, you know, small VSD or residual VSD, in case it comes after 1 or 2 months, you can go as you do to the right atrial approach, because you can fix it. Second thing is, because the anterior wall is, and the second approach is going through the same area, go to the anterior wall, because this is infarction. It doesn't contribute anything. Yes, the LV. The important thing is never try to open the RV. Never go through the RV approach, has been totally abandoned because of the RV dysfunction, can cause a post-op, you cannot fix it. But because the LV is infarcted, so better go to the LV and open and fix that. Was this question, what was your question? Did I answer your question?
Yes, thank you.
Yes, these RA approaches have been, I will say one of the, I remember, you know, when I was long back, you know, one of our senior consultants, he did an RA approach. He must have read some paper from the Japan, he did. Then We went out of OR after second day, patients started, again, developing edema, sinking and never stop. Then we did an echo. The whole patch was gone. It was nothing. We couldn't see it. So you will read this in literature, lots of things about this, because nothing is fixed protocol. Some people go RA, some people go LV, then none of the, but you will not see anybody going to the RV approach. So yeah, you can see that different things, double patch, triple patch, glue, not glue. But what if you see this, Tyrone David paper in 1995, long back, he did just 6 died, 14% mortality, wonderful outcome. And I personally feel, don't go to the necrotic, you will have a residual VSD. I don't have a residual VSD, alhamdulillah, it is that going through the, but when you put a patch, you think, LV is small. So that is why, you put a little bit bigger patch, redundant. When the LV tries to fit, your patch pushes to the septum. So the feeling is good. Yes.
Dr. Shabir, I noticed there is nothing mentioned about mitral post-op, mitral function post-op in your cases. So all of your patients, there is no mitral dysfunction after surgery?
Mitral valve regurg?
Yes.
Oh, okay. So as you said, I did a 7, anteroseptal this VSDs. None of them had an associated mitral valve disease. That is true. That is true. That is true, yes. There is literature, as I say, it is textbook basically. If you open the Lawrence, you will see the 20% have an associated. But clinical practice, I didn't. Even you go through literature recently from last 1 or 50 decade or so, there has nothing has been mentioned. The mitral valve disease is commonly associated with it. Particularly anterior, no. So I didn't appreciate.
Okay, thank you.
Any more questions?